morning and welcome to our virtual grand rounds, and I'm glad to have you here this morning. The good news for you is I will not have to urge you to move to the front of the auditorium this time. But welcome. I'm going to have the pleasure of introducing my colleague for the last 3.5 decades, Dr. Mike Reardon, who actually needs no introduction. But first, I'm told to remind you, we will show you the numbers to text to. So text questions, we'll address them after the lecture. And we'll show you the online URL to connect to if you'd like.
Right.
So, Mike, you really need no introduction.
Well, thank you, Neal.
It's embarrassing to actually have to introduce you at this point, but Michael's one of the guys who really, I mean, if nothing else, has determined.
Yeah. Well, thank you, Neal. Listen, it's a pleasure to be here with you. And so Neal and Steve Little and I are responsible for the structural heart program here at the Methodist Hospital. We thought this morning we'd talk a little bit about where we stand with TAVR. The low-risk trials are done. The data is in. The FDA has approved this for low risk. So what does the data tell us, and what does that mean? And that's what we're going to focus on this morning. So these are my TAVR conflicts of interest. I've had the opportunity to run a number of the trials out there. We really aren't going to speak very much to specific valves, but I do want to talk about the data. I think it's very important for you to understand the data. Now, if we start with the extreme risk trials that were done, there was first a partner 1B, which was TAVR with the balloon expandable valve randomized against best medical therapy, which could include balloon or valvuloplasty. And what we saw was a 20% advantage for the TAVR arm in every year of the study out to 5 years. When we did the core valve extreme risk trial, we wanted to pattern it after this, but the partner 1B was already out. It was no longer ethical to randomize against medical therapy. So we used a performance goal of the 95th lower border of the partner survival, plus 5 contemporary BAVs. And you'll notice that we beat the objective performance goal. And in fact, the 5-year TAVR survival is exactly the same in both trials. So FDA approved it for extreme risk or non-operative candidates. So then we moved to high-risk trials. Partner 1A randomized balloon expandable against surgery, and then the core valve high risk did the self-expanding against surgery. And in this trial, we used a all-cause mortality metric as the primary endpoint, and in both of them, in the high risk for the balloon expandable, there was no difference out to 5 years. For the high risk self-expanding, it was actually superior survival for surgery in years 1 and 2, but by the time you reach year 5, the survival is exactly the same. And so the FDA approved TAVR for patients that are high surgical risk. Then we moved into the intermediate risk for balloon expandable. It was the partner 2A trial. It now has a primary endpoint of all-cause mortality or disabling stroke. And what we found was that there was no difference. It was non-inferior all the way out to 5 years. We did the same thing for the self-expanding in the SUR-TAVI trial, using a Bayesian analysis to predict a 2-year endpoint, and that showed no difference between all-cause mortality or disabling stroke. In fact, we've done a complete 2-year data now using standard Kaplan-Meier, and there's no difference. It did not change. So this was now approved by the FDA. So that finally brings us down to the low-risk population. Now, low risk was defined as patients that were thought to have a potential surgical mortality by the heart team of 3% or less at 30 days. So now you have the partner 3 trial, which is balloon expandable, and you have the Evolute low risk trial, which is self-expanding. In the partner 3, you're going to randomize 1-to-1 surgery against TAVR with the balloon expandable valve. You had to have transfemoral access to do this. There's going to be a leaflet thickening and immobility sub-study, and these patients are going to be followed out for 10 years. In the self-expanding, it's going to be 1-to-1 self-expanding versus surgery. This is going to be stratified by the need for revascularization. So in the TAVR arm, you can have PCI, and the surgical arm, you can have surgery. It too will have a leaflet thickening immobility 4D CT sub-study, and it too will be followed out for 10 years. This is the study population. As you see them going down, you notice that there's some fallout on both sides, but more on the surgical side than the TAVR side. This is something we've seen in all of our trials. Certain people that entered the trial and got randomized to surgery just dropped out of the trial. Now, the other thing that's important to understand is there's a different endpoint here. Remember, in the high-risk trials, the primary endpoint was all-cause mortality. Intermediate, we moved to all-cause mortality or disabling stroke. And now in the partner trial, they used all-cause mortality, all stroke, or rehospitalization. And in the self-expanding low-risk Evolute trial, we used all-cause mortality, disabling stroke, but we used a Bayesian analysis. So why do we do this? Well, as you move into a low-risk population, the number of events we see are going to grow smaller and smaller. So you either have to add patients, which is extremely expensive, add time, which can be expensive too, or add events. So the partner group chose to add events by adding hospitalization. On the Evolute low-risk trial, which I ran with Jeff Popma, we were a little worried about that because if you went on hospitalization alone, it was going to be hard to move the needle because patients would say, well, hospitalization, our surgeons might say hospitalization is not that important. So we stuck with really hard endpoints of all-cause mortality, disabling stroke, but we used a Bayesian analysis which allowed us an early look and to predict two-year endpoints so we could get the data out potentially earlier using this well-known analysis procedure. Now the other thing that's different is that when the Partner 3 trial started, the SAPIEN 3 third generation balloon expandable was already out and the operators were well versed with how this was going to be done. In the Evolute low risk trial, we had about 3.7% first generation core valve, we had about 3/4 second generation Evolute R, and only about 22.3% third generation Evolute Pro. And in fact, we were introducing these valves as the trial went on, so we didn't have one single valve, we were learning as we went. Now, if we look at the baseline characteristics, there's certain things that look very much the same. The median age is between 73 and 73 and a half and 74 years old. Intermediate risk had been 80, high risk had been 84, so we're coming down, but we're still not that young. It was interesting, there was a 50-50 split between male and female in the high risk and extreme risk, but now it's now 1/3 female and 2/3 male. We really wondered why that might be, and I think part of the problem is if you're a female in the US and you have open aortic valve surgery, just by being female, there's an added risk in your risk score. Why is this? Is this because females are less strong than men and they just can't get through the surgery? No, of course not. The reason is that females in general are smaller than men, so they got smaller aortic valves and the aortic stenosis was relieved less well. And since the flow has to do with the square of the radius, as you reach a certain point of smallness, it becomes more and more important. So we only had 1/3 female, which is a little bit different. And if we look at the SDS predicted risk of mortality, it was 1.9 in every arm of both trials. So very similar on at least the patient demographics. Now we go to the primary endpoint. Remember, for the Partner 3 balloon expandable, it was all-cause mortality or stroke or rehospitalization, and easily passed the non-inferiority. In fact, it made superiority. The endpoint for Tavor was 8.5%, and for surgery it was 16.1%, and that reached superiority at the p less than 0.001 level. If you look at the Bayesian endpoint estimate for the all-cause mortality disabling stroke for the low-risk Evolute trial, for surgery it was 6.7, and for Tavor it's 5.3. That was easily non-inferior because it gave you a posterior probability of greater than 0.999. For those of you that need a p-value to feel comfortable, if you subtract the posterior probability from 1, you'll get an approximate p-value, and it would be less than 0.001. And in fact, both these trials ran multiple sensitivity analysis. I certainly know more about the Evolute low risk because I ran that with Dr. Popma. And in fact, we did everything, including a worst case scenario, where every surgical case that dropped out to have data was assigned as no event, and every Tavor that we had no data on was assigned an event to try to make it as bad as we could for Tavor, and it was still non-inferior. So let's look at some Kaplan-Meier curves since we're really more familiar with those. This is Kaplan-Meier for 1 year all-cause mortality, where the balloon expandable is on the left-hand side of the slide and self-expanding is on the right-hand side of the slide. And first thing you notice is that at 30 days, the mortality for surgery is 1.1 and 1.2% in the two trials, and for Tavor it's 0.4%, about 1/3. This over and over again has shown itself to be a very safe procedure. Then we come out to 1 year and you see that surgery is 2.5 and Tavor is 1.0 in the balloon expandable, and in self-expanding it's 3 and 2.3. So Tavor is numerically less but not statistically different in both trials. Both numbers are lower in the balloon expandable than self-expanding. Why? Because they actually chose a lower risk population. Your risk is really defined as how well you survive after you get through the procedure. And so both these numbers being lower just shows they chose a slightly lower risk population. Nothing wrong with that. It's just one of the differences you need to understand between the two trials. If we look at stroke, which is something that's concerned us all, since the Partner 1A, which was the first trial that showed a higher stroke rate in Tavor, every other Tavor trial that's been randomized has shown a statistically or numerically less stroke rate. In fact, both of these, if you look at the stroke at 1 year, in the balloon expandable, 3.1 for surgery, 1.2 for Tavor. And in the self-expanding, 2.3 for surgery and disabling 0.7 for TAVR. Both of these are statistically significant in favor of TAVR, something that we've seen. You look at rehospitalization, we knew that rehospitalization was superior in the balloon expandable, but it's also superior in the self-expanding when you look at this. So this is something that gets you out of the hospital quicker, safer, and you stay out of the hospital. And in fact, in the self-expanding, if I take a 3-part endpoint, much like they did in the PARTNER 3 trial, and use all-cause mortality or disabling strokes or rehospitalization, we see that it's statistically superior for TAVR. So this is one thing that really made this very strong when this was presented at ACC last year, and it's one of the reasons why when Brunwald talked about it, he said if you're sitting in the room right now, you're sitting here in a historic moment. Things have really changed. So if you looked at the conclusions that Marty Leon gave when he presented this for the PARTNER trial was that based on these findings, TAVR through 1 year should be considered the preferred therapy in low surgical risk aortic stenosis patients. My conclusion when I presented this was TAVR may be the preferred strategy to surgery in patients with severe aortic stenosis at low surgical risk. The caveat on both of these is that like all randomized trials, it applies only to the population tested, so it's very important for you to know the trial data and know who was tested and who was not tested. So what were the differences in the trial? Well, there's really only 2 real differences in these trials as far as I'm concerned. The first is pacemaker. In the balloon expandable trial, there was no statistical difference in the pacemakers. It was 4.0 for surgery and 6.5 for TAVR. That was not statistically different. And in the self-expanding trial, it was 6.1 for surgery and 17.4 for TAVR. And so that was statistically significant in favor of surgery for the self-expanding valve. Now I went back and looked at every site and how many cases they did and what their pacemaker rate was, and what you can see is that the sites that have more experience had a lower pacemaker rate. This really has to do with how the depth of implantation, how well you can implant these valves, and as you do more, you get better. In fact, if you look out in the far right, this is my highest implanter, Hemogata. His pacemaker rate was 1.9%. This is our site. Our pacemaker rate was 5.6%. So it's really dependent on how you implant the valve, and we're learning a lot about that. The other difference was hemodynamics. Typically, TAVR valves have had hemodynamics that were better than surgical valves, and in the PARTNER 3, for the first time ever, surgery actually had better hemodynamics than the balloon expandable valve. Now, part of that is because there are more men, there are bigger valves, and surgeons put in bigger valves. In the self-expanding, TAVR was better than surgery at every time point, and this is what we've seen in every single one of our randomized trials. So these trials are now done, we've reached our endpoints, and it's now FDA approved. So there's no longer a risk stratification for who gets TAVR. And again, remember, this is a patient choice and it's a population only. Same thing that we decided. And the thing is with these is that safety was the key difference in outcomes in both trials, with most of the benefit occurring in the first month. And after you get it past 1 month, these curves tend to flatten out. So why is that? Well, when we did the high-risk trial for the self-expanding core valve, and it was actually statistically superior for TAVR over surgery for survival, I was a little shocked by this. We were actually the high, Dr. Kleiman and I were the high enrollers in that. We implanted more valves and did more surgery than any other site in the US, and we lost nobody. I thought surgery was going to win. So I went and created these instantaneous hazard risk of death curves for TAVR and SAVR. And as you can see, there's a high instantaneous risk of death in the day of your procedure because that's when we're doing something. And for both lines, the yellow line for surgery and the blue line for TAVR, it fell to 1 month, and then TAVR stayed down. Surgery went up at a month and didn't come down to 4 months. And in fact, it's only that 1 month to 4 month where TAVR was actually statistically superior to surgery. So why did surgery go up at a month? Well, our definition of mortality for surgery is death within the first 30 days or in the hospital. And if I keep you alive 30 days and send you to a long-term care, like a SNF or an LTAC, and you die there, it's not a surgical mortality, but it is a mortality. And that's what happened in these older patients who are often in their late 80s. They got out of the hospital, but they never could fully recover. So what happens when we move to intermediate risk? Well, what we see is that the procedural risk is lower for both, still higher for TAVR than surgery, but closer. They both fall to 30 days and they stay down. That's why there's no difference in mortality. These are younger patients with a mean age of 80, and they don't tend to die at month 2 or 3. They're strong enough to recover. So how about low risk? Well, now the procedural risk for TAVR is actually less than surgery for the first time, and they fall down. And so what we see is that procedural risk for surgery is decreased some because you're doing less risky patients, but for TAVR it's increased a whole lot more because it's not just the patient population, it's we're learning how to do this better, we're getting better devices. And surgery is a very mature procedure, it's probably not going to improve much more. TAVR is still in a rapid improvement phase. So if I looked at the causes of death in low risk, what I see is there's 3 causes of death in the first 30 days. 2 were coronary occlusions and 1 was a valve that popped out and caused a dissection for the TAVR. These are all technical problems that should be easily solvable. For surgery, most of the death were complications related to the procedure and use of the heart-lung machine. Something that as surgeons, if we're going to do better, we've got to learn to get past these complications. And the TAVR field is getting over these technical complications very quickly. They used to be fairly common. They're becoming very, very uncommon in the hands of experienced operators. So where are our knowledge gaps as we start thinking about who we should treat? Well, one is bicuspid valves. We use the Sever's classification of bicuspid valves. It has to do with the number of Raphés we have. There's type 0 with no Raphé, just 2 equal leaflets. There's type 1, which is by far the most common with 1 Raphé. The most common is a left-right fusion. And then there's a type 2 with 2 Raphés, which is almost like a unicusp valve. Now, when I was training, I was always taught that bicuspid valves occurred in young people, and by the time you got older, you were having what we call degenerative aortic stenosis. But what we find is even in our 80-year-old plus population, more than 20% are still bicuspid valves. Now, 2% of the population in the U.S. are born with bicuspid valves, but by the time we start operating on them, it's a much higher percentage because these are the valves that go bad. So as we move down to the population that's in the 60 to 70 range, we're probably going to see bicuspid valves in 50% or more of our patients. Bicuspid valves were not allowed in any of the randomized trials, and so it's a real knowledge gap. Now we're starting to get some information. This is from Yoon at Cedars-Sinai in LA, looking at the outcomes for bicuspid valves and tricuspid valves. And what they did is looked at the TVT registry and looked at bicuspid and tricuspid valves. They came down to a propensity matching score, giving us 546 pairs. And with early generation valves, what they saw was that there was more root injury, more second valves, more paravalvular leak, and more new pacemakers. But by the time we moved on to the 3rd generation valves, now we're seeing no real differences and the risk is dropping. And we're really all using 3rd generation valves right now. This is looking from Raj Makkar, the association between TAVR and bicuspid tricuspid valves in another study, and he matched the populations, and what he showed was that there's no difference in mortality out to 12 months. He now looked at the TVT registry, which is a transcatheter valve therapy registry. There was over 80,000 valves for him to look at. He could then propensity match and come up with over 2,600 matched pairs. And what did he find? Well, what he found was that compared to open surgery, there was a greater chance with bicuspid valves needing to be converted to open surgery, but it's less than 1%. A greater chance of annulus rupture, but again, it's the difference between 0.3 and 0, and a greater need for a second valve, but that's the difference between 0.4 and 0.2. All very low numbers for both valves. All stroke was higher for bicuspid valves, 2.4 versus 1.6. Again, both low numbers, but something of a little concern. And pacemakers were slightly higher in bicuspid valves, something we see in surgical cases also. However, there was no difference in the mortality in the matched pairs at 1 year and no difference in the strokes in the matched pairs at 1 year. So this is some optimism about bicuspid valves. But you have to remember in the TVT registry, the operators were allowed to see these patients and decide who they wanted to treat with TAVR and who they wanted to send to surgery. So these are somewhat selected cases. This is John Forst's work looking at the self-expanding valve in the TVT registry. John had almost 46,000 valves to look at. He could look at it 1st generation core valve, 2nd generation Evolut R, and 3rd generation Evolut Pro. And what he found is we moved to the 3rd generation. By the time we got to the 3rd generation, paravalvular leak, moderate or more, was only 1.3%. And it's gone down markedly as we move through our generations of valves. The primary results from the Evolut low-risk bicuspid registry with a central core lab for the CT and echo readings will be presented by Basler and Molly in about a week virtually for the ACC, since that meeting's not being held in person. It'll be presented much like this Grand Rounds is being presented. So what are the other knowledge gaps? Well, we talked about the mean age. The mean age was almost 74 years, But if you look at the partner trial, only 7% of people were less than 65. And for the Evolut low risk trial, only 6% were less than 65 and only 1.3% were less than 60. So I have patients coming into my office every day going, well, low risk is approved, I want a TAVR, and they're 55 years old. And I have to tell them, you know, we can talk about this, but we really don't have any data on people like you. Most of the data is generated on people that are 74 years of age. 74-year-olds statistically have about 13 to 14 years left in the life table analysis. We have some fairly good durability that looks like it's getting out to 8 and 9 years. But if you're 55, you're going to live 30 more years. We don't know about that yet. So what's the other issue here? Well, here's what I showed you before. This is the patient flow through the study, the patients that dropped out. When these patients are seen, they're seen by the local heart team who has to sign off that they meet all inclusion and exclusion criteria for the trial, and they are anatomic and physiologically appropriate for both surgery and TAVR with the valve considered. One would think that these experienced heart teams would then send them up to the National Screening Committee who would end up approving virtually everybody. But in the Partner 3 trial, 34% of the patients were screen failed at the national level after they'd been approved at the local level. And in the Evolut trial, 14.8% were screen failed at the national level. Now, having run the screening committee for Evolut, I can tell you that every once in a while, the numbers the site sent up and the numbers that we measured at the core lab just didn't match, and sometimes their numbers were out of window for the protocol. But there's also an exclusion in both trials for excessive LVOT calcification, which is very hard to define, and there was some selection for patients that looked like they'd be good for TAVR, and not necessarily and not good for TAVR, but okay for surgery. And so clearly, if you have a trial that's excluding 1/3 of the patients after they've been approved locally, neither one of these trials apply to the entire population of low risk out there, something that you need to bear in mind. So let's move on to how these valves work and patient prosthetic mismatch. Patient prosthetic mismatch is a concept brought to us by Ramatula back in the 70s, basically saying that the valve does not have hemodynamics that are adequate for the needs of the patient. Now, the way we define it now is a indexed EOA of less than 0.65 is considered severe patient prosthetic mismatch. Between 0.65 and 0.85, it's moderate. There's some modifications for obesity that are made. There's some question about whether these are really valid anymore. But remember, 0.65 is less is severe, 0.65 to 0.85 is moderate. Above that is considered normal. So in the high-risk trial, we looked at the degree of severe patient prosthetic mismatch at 1 year between TAVR and SAVR. It was 7.7% for TAVR and 20.7% for surgery. Did that make a difference? Yes. If you had severe patient prosthetic mismatch, it was a marker for mortality and your survival was decreased. It's not good to have mismatch. And in fact, one of the interesting things we found about this trial when we looked at it was we looked at the cases divided up by the size of the annulus, where we're going to put the valve, not based on the surgeon's estimate, but based on the CT scan read by a CT core lab. And we divide them into 3 groups, what would fit a small, medium, or large TAVR valve, and then looked at the surgical cases done in those groups. You notice going from large to small in the TAVR, there's no change in patient prosthetic mismatch. But if you go from large to small in surgery, there's a marked increase in the patient prosthetic mismatch. These TAVR valves are like stentless valves. They perform much better. And the smaller your annulus, the more benefit you get out of these. This is one reason why women do so well with TAVR, because anatomically they're smaller than men. And they're going to be in that small annulus group, and they're going to avoid patient prosthetic mismatch more often with a TAVR than with surgery. In fact, we did the same thing in low risk to see if it still applied, and yes, it still applies in low risk. So these valves perform much better than surgical valves, the self-expanding, and they do better and better as you go to smaller annuluses. So what's out there in the country right now? Well, again, the TVT analysis. Everybody gets a TAVR in this country, puts their data into the TVT registry. This is Howie Herman's paper, and Howie looked at the amount of patient prosthetic mismatch out there in the TVT, and severe is about 12.7, and moderate's a little over 24%. And if you had patient prosthetic mismatch that was severe, at 1 year you had decreased mortality. So even for TAVR, patient prosthetic mismatch is bad, just like it is for surgery. And in fact, this is Philip Peebrow's look at all the randomized trials out there and the rate of patient prosthetic mismatch in TAVR in blue versus surgery in red. And then below you see the relative risk increase from patient prosthetic mismatch. And everybody in any trial that has patient prosthetic mismatch, it was a relative risk increase for your mortality. So this is the Evolut low risk. If you were in the Evolut low risk trial and you were assigned to surgery versus TAVR at the end of 1 year, your risk of having moderate to severe patient prosthetic mismatch was more than 5.5 times higher than it was if you had TAVR. So if we look at what we know from the surgical literature, this is Fallon's look at the STS, and what Fallon did was Fallon looked at over almost 60,000 patients that were over 65 having isolated aortic valve replacement, and looked at those with patient prosthetic mismatch. And what Fallon showed from the US data on surgical valves, if you had any degree of patient prosthetic mismatch, it was a marker for increasing your mortality and increasing your readmission for heart failure or structural valve deterioration. So again, not a good thing. Stuart Head's paper, which is a meta-analysis showing the exact same thing. This is a paper from Kleiman from Germany. What he showed is if you had patient prosthetic mismatch, it was a marker for early structural valve deterioration. And what he showed was that the markers for structural valve deterioration, you see here, female gender, small body surface area, small valve, and a small EOA. But the only one that was a marker for mortality and structural valve deterioration was patient prosthetic mismatch. This is Doug Johnson's work from the Cleveland Clinic, and he showed if you had a surgical valve and you came out with a mean gradient over 20, your risk of structural valve deterioration rose exponentially, something we've looked at far more commonly in surgical valves than in the TAVR valves. This is Becky Hahn's paper. Becky is an echocardiographer up at Columbia. She's been a real leader in this field, and what Becky did was take the randomized balloon expandable and self-expanding trials and look at the echo core lab data, and the mean EOA for the SAPIEN 3, the third generation balloon expandable, was 1.66, and for the Evolut it was 2.01. She also created these tables. We configured about the SAPIEN and SAPIEN XT. We don't use those anymore. We use SAPIEN 3, and from the small to the large, you see an increase in the EOA and a decrease in the green gradient, but look at the DVI, the dimensionless velocity index. Since that's a ratio, it doesn't change with valve size. It's about 0.42 in all valve sizes. We move to the self-expanding. We don't use first generation. Again, the valves get bigger as you go up, the EOAs get bigger, the gradients go down, but now the DVI is about 0.61 across. So it's about 30% better in all the valves, because it's a supraannular valve versus an intraannular valve, and it's a function of the valve itself. We see the same thing when we look at the Lotus valve, a trial I ran with Ted Feltman. It's another intraannular valve. DVIs are about 0.42. This is back from 1955. This is from Gorlin when he was originally working out the flow of aortic stenosis. And this is what I want to show you. This is what Gorlin did was he looked at aortic flow versus mean gradient at different families of fixed EOAs. So what's the normal flow across aortic valve? It's about 220 cc's a second. What's high flow when you exercise? It's over 500 cc's a second. So if you look at this curve and find the EOA of 1, if you're sitting at rest and your normal flow is about 220 cc's a second, your mean gradient's about 40. If you exercise, your mean gradient goes up to about 150. That's why people with aortic stenosis die when they exercise. Now we have to remember that most of our echoes are done at rest, and we're not seeing what happens to people as they exercise. You also notice as we go from 1 to 0.8 to 0.6 to 0.4 to 0.2, we're changing by 0.2, there's a larger increase in the gradient. Why? Because it's related to the square of the radius of the opening. And as we go from 1 up to 2, which is where the most surgical valves sit, is the upper half of this, you realize you have to get to an EOA of about 2 before you can really increase your flow without increasing your gradient. So does that make a difference? Well, this is a 6-minute walk test we did in the TAVR trial. Everybody got a 6-minute walk at baseline, 30 days, 1 year, and 2 years. Not surprisingly, at 30 days, TAVR increased their 6-minute walk a lot because we don't do much to them. We just poke their leg. Whereas surgery still hadn't recovered from surgery, so their 6-minute walk actually went down. We know that transfemoral TAVR has a better quality of life at 1 month than surgery, but by 1 year, surgery catches up and they're equal. So you'd think that the 6-minute walk will catch up, but it doesn't. It's still statistically superior for TAVR at 1 year and at 2 years. Now I see two possible explanations for this. One is TAVR gives you EOAs with this valve that we tested of 2 and above. And so these patients can actually increase their activity without increasing their gradient. Now the other possible explanation is all of us that have done this for a long time understand that certain people that have heart surgery never let themselves get better. Once they've had heart surgery, they consider themselves disabled and they just don't get better. But certainly having larger EOAs, particularly as we move to younger patients who want to be vigorous, becomes more important. And in fact, as I start to think about this, this is how I look at it. The yellow bar, the red bars are the life table analysis. The upper right-hand corner is the survival of pericardial surgical valves. So if you're 80, you're going to live about 10 years, and your risk of your surgical valve wearing out is about 4% in your lifetime. So far, TAVR valves seem to be tracking surgical valves for durability. If you're 80, we know the durability. It's a good trade-off. If you're 80 and you're anatomically appropriate for TAVR, you probably shouldn't have surgery. It doesn't make any sense anymore. How about 75? Well, now you're going to live about 13 years, and your risk of this wearing out is about 6 or 8% in your lifetime, and that's the low-risk trial, 74, 75 years of age. If you're anatomically appropriate, you should probably have a TAVR. Well, now how about if you're 65? Well, now we're getting down there. There weren't many people less than 65. You're going to live a little over 20 years, and your risk of this wearing out is now getting up to the 18% in your lifetime. So this is how we as surgeons make our decision between mechanical valves and tissue valves that wear out over time. But now we're going to have to start making decisions about when do you move to TAVR. And it's going to be fairly similar to the decisions we make about when do you go from tissue to mechanical valves. We've been arguing the cutoff there as surgeons for decades. We're unlikely to get a solid answer for TAVR in the very near future. So what's happening out there in the universe of TAVR? Well, this is the TAVR data and the surgical data. The purple line on the bottom is aortic root replacements, like Bental's. The green line is going to a surgical aortic valve replacement plus a CAB. The orange line is surgical aortic valve replacement plus another valve. The red line that's horizontal is isolated, the orange line is isolated aortic valve replacement, and the blue line on the very top is all aortic valve procedures added together. The red line that you see rising rapidly is TAVR in the US. And in fact, what you can see is that sometime in 2015, TAVR surpassed isolated aortic valve replacement, and it's never going to go back the other way. What you don't see here is the data is in for 2019, where we're going to do over 75,000 TAVRs, and we've now crossed the all aortic valve procedures. And again, that's not going back either. Most of our access is transfemoral. Our access at the Methodist Hospital is 98% transfemoral, and most of the rest is either axillary or carotid. I haven't done a transapical or a direct aortic in several years now. And most of our TAVR patients go directly to home. People that go directly to home rather than some sort of rehabilitation tend to do better. And the other thing that we're going to see happening is our population is no longer so much of a pyramid as a cylinder. People are growing to be older and older, and more of these patients are going to be candidates for transcatheter valve replacements as opposed to open surgery. This is an estimate of the annual numbers that would be done based on a study in Europe. This is if intermediate risk was added, which has been added, and we saw it go up like this. This was if low risk was added, and this is exactly what we've seen so far. We're up almost to 80,000. My prediction for 2020 is we'll do 100,000 plus TAVRs in the United States. This is another study that's really interesting out of England, looking at the underdiagnosis and treatment of aortic stenosis, and they looked at community clinics and echoes, and what they found is the blue is people that are diagnosed with severe aortic stenosis and get some sort of treatment. The red are people they identify as having severe aortic stenosis, but they never get referred for any kind of treatment. The number of people out there with severe aortic stenosis and symptoms are probably double that what we're treating right now. Many of them are just afraid to come in, or their family doctors think, well, they're 80, they're too old to have anything done. And I think as TAVR grows, we'll be seeing that patient population. So what do the randomized trials tell us? Many more cases will be done, but not all low-risk cases will be appropriate for TAVR. That's why it's very important for us to have very strong heart teams where cardiology and surgery are both well represented, so we can make the best decision for the patient based on the anatomy and physiology of what we see, as well as patient desires and choices. Excellent outcomes are imperative. In the early days of TAVR, every once in a while you lose somebody. That was, it's the nature of the beast. It's no longer the nature of the beast. We expect these people to come in, go to the recovery room, go to the floor, be walking around that afternoon eating a regular dinner, and home within 1 to 2 days. And patient selection is the key. If you choose the wrong patients, you will end up getting some bad results. Again, it's very important to have a very strong heart team, each and every one of these. So how do we choose? Well, if I'm going to do TAVR versus aortic valve replacement, I want to have the same or equal mortality. We've seen that in all the randomized trials. Hemodynamics, we've seen that in all the randomized trials. Morbidity, the things like stroke and paravalvular leak, which used to early on kind of bedeviled TAVR, are getting better. There's still an issue with pacemakers for some of the valves, but not all of them. Quality of life, TAVR beats the pants off of surgery for early quality of life. Durability, we still don't know, and it's probably going to be another 6 to 8 years before we have a better feel for this. But so far they seem to be tracking surgical valves. And patient acceptance, you don't need any data on that. Everybody that walks into my office wants to have a TAVR. They've read about it on the internet, they bring in their Google search for me and say, listen, I've looked this up, doc, I want a TAVR. Every once in a while I tell them, well, your problem's not your aortic valve, you need a coronary bypass. They said, I'd rather have a TAVR, it seems really good to me. Everybody wants a TAVR. In fact, they get referred in from the referring cardiologist. Oftentimes they're not good candidates, and I have to then sit down and explain to them why they need surgery. If I just tell them I'm going to operate on you, they'll leave my office. If I have a reasoned conversation, say this is why you need surgery, this is why you're not a good TAVR candidate, then they'll usually say, okay, I now understand that. So what are the big things? Like real estate, location, location, location. Here it's age, age, age. As I said, if you're 80 years old and you're anatomically a candidate, there's really very little reason to have an open operation anymore. Lifespan, we know life table analysis, but everybody's a little bit different. There are 65-year-olds that I see that I doubt are going to live another 10 years. And there's 80-year-olds who look like they're going to live another 20 years, so we need to take that into consideration. And there's an anatomy that becomes very important for us. If there's a lot of calcium along the LVOT, left ventricular outflow tract, we as surgeons can take that off very easily. We can debride it. That can be problematic for TAVR. And if you're younger, some of these people ought to have surgery. And choice, patient choice makes a big part of this. And not only patient choice, but it's important to sit down with your patients and ask them, what is it you expect from your treatment? Sometimes what they expect and what they want are different than what doctors expect and what doctors want. So it's important to broach that conversation with your patients. Anyway, thank you very much. It's a pleasure to talk to you this morning and talk a little bit about where we stand with TAVR. This is a growing field and something that we at the Methodist Hospital have had the opportunity to be a leader in, and I look forward to answering any questions you may have. Thank you. So I'm waiting for questions to come up. As I'm waiting for questions to come up, I can tell you that sites that don't have TAVR, I think going forward, it's going to be very hard to have structural heart programs that include surgery, because patients are seeking out places where they can be seen by valve teams that can offer this as an opportunity. And of course, TAVR is just one of the transcatheter valve therapies that we as a heart team are applying. We have mitral valve therapies, we have pulmonary valve therapies, and we're exploring tricuspid valve therapies. We certainly think that within the next decade, we're going to be approaching all these valves with transcatheter therapy options for patients, and we're even running an early feasibility trial for stent grafting for the ascending aorta for aortic dissections. So I think the field is changing rapidly into a less invasive field, and I think that people will seek out reference centers like ours for their treatment. If there's no further questions, I think some are coming up right now. The one thing about doing this thing electronically, instead of getting to look everybody in the eye, is there is a little delay in our communication. But this allows me to be socially distanced from you. And even my camera guy is 12 feet away. So we're doing really well here this morning. Okay, I see some questions down below, but they're going to have to go full screen because I'm old and my eyes can't read the tiny print. So how do you train young cardiac surgeons to do TAVR safely? I think that's a really good question. I think one of the things that we've been very focused on here at the Methodist DeBakey Heart and Vascular Center is education, and how do we train our young surgeons. Our vascular residents spend a lot of time doing endovascular stuff, and our cardiac surgery residency, which is starting, will also spend time doing endovascular stuff. We have 2 surgical fellows and 1 cardiac surgery, one cardiology fellow that are structural heart fellows with us, doing TAVRs with us. They're hands-on helping us do this. And I think going forward, wire skills are going to be very important for a subset of surgeons to maintain. Not every surgeon is going to do TAVR, not every cardiologist is going to do TAVR, but it's going to be important for every heart team to have a subset of cardiologists and a subset of surgeons that do that and do this well. Do you see structural heart moving into the I'm not sure what the ASC setting is, but it's going to expand without any question. And it's probably, as this gets safer, move out in the community. We've already started one of our community sites, Sugar Land. Michael Coe and Marvin Atkins run that program. We're getting ready to start up West Houston. But as the risks go down and the procedure gets better, this is going to expand and continue to expand. So I'm joined by my partner, Alan Lumsden, who heads our heart center. Alan has been a leader in education for both vascular and cardiac people. We have a very tight group that works together. Low fidelity simulator for mastering hybrid procedures at home, those are out there, and yes, we do training on simulators. It is very good to figure out how the steps go, and then we can help move you into normal people. But every one of these trials starts by teaching people on simulators. Are there useful center addresses in order to apply for training hybrid procedure in the USA? Well, here at the Methodist Hospital, we have both interventional cardiology and structural heart fellowships for hybrid procedures. We can certainly get you the addresses to that later. Alan, do you have any comments you want to add?
I think that question was the ambulatory surgery center. Do you ever see this going in the outpatient environment?
Yeah, okay. Well, so it's moved to the outpatient environment in Europe. There are outpatient centers that do this with a surgeon that just drives over and sits there during the case. As a heart surgeon, I'm a little worried about this because the number of disastrous complications are low. They're less than 1%. But when they happen, you have just moments to rescue your patient. And in low risk, we don't expect anybody to die, ever. And we've done well over 2,000 of these. There's just been a handful where things have gone bad very rapidly, but having a surgeon at the table and a cardiology team and a surgery team works well together has allowed us to basically rescue these people. I personally would be very worried about having my TAVR done at an outpatient ambulatory center.
So we tend to do them in the hybrid room, but a lot of places have moved up into the cath lab.
Yeah.
I think a lot of them can be done in the cath lab. Yeah. Are there cases which absolutely should be done in the hybrid room?
Yeah, there are. There's certainly cases of bad left ventricles, bad right ventricles, really bad anatomy with a lot of calcium where there's a risk of annular rupture and other things. So yes, you can do these in a cath lab, and if you choose the right patients, 99% of the time it's going to go okay. What do you tell the patient's family when they're the 1%? And you don't rescue them. I think that we certainly do ours in the hybrid room because we're committed to patient safety and excellence outcomes.
Thank you.
Well, listen, if there's no other questions, thank you very much for joining us this morning. We're always available at the Methodist DeBakey Heart and Vascular Center to answer your questions, and we have a great training facility here, so come and visit us and visit our YouTube channel. Thank you very much.
Very good.